Welcome to the HST review of the PACU/post-op workflow. We will cover phase 1 and phase 2 of the recovery process in HST ECHART. Let's go over a few bits of information first. HST ECHART is a browser-based application. Anywhere that you can access the Chrome browser, you'll be able to access HST ECHART. When you first log in, the schedule page will appear in front of you. The schedule page has many unique features, including the ability to see that there are documents attached, that there is an scheduling note, which is the yellow dog here, and the yellow dog here with a red dot, which is a clinical note. You do not have to open the chart to see that information. You simply tap and hold. The flyout will tell you when the patient checked in, the document that is attached, and the clinical note that has been assigned. Let's jump right into the eChart. To open eChart, you simply tap on the patient's appointment. It will open you to the current visit summary page. You can, if you'd rather, have it open directly into your workflow. So what is a workflow? HST eChart is divided up into clinical areas of care. Those areas of care are designed so that the user does not have to leave their workflow to complete the documentation on their record. But let's point out a few other interesting things. Well, the first page that you come into is called the current visit summary. This page will auto-populate for the user as the patient continues through the procedure. No interaction is required. Any medicine given, any vital signs taken, any home medication, allergy, problem list, in-house lab results, and documents attached to the record will automatically update as the patient moves through the continuum of care. You can also look at the previous visit summary, which is a hyperlink to the previous visit's chart, if you needed to know how that patient did in recovery, or if anesthesia needs to look up how that patient was put to sleep in a prior visit. The next tab is where you would add clinical notes or add to the clinical note that was added. There is lab pathology, specimen reconciliation, patient portal data if you use an outside patient, and the ability to e-prescribe directly through eChart. In the center, you'll notice the patient's picture. You'll notice their height, their weight in kilograms in case you need it for urgent medication administration, and their BMI is in the anesthesia row. You'll also notice on the far right, the yellow is a chart completion indicator. When you are on the current visit summary or the chart home, it will tell you the completion of each of the areas of care. When you are in a workflow, it will tell you just that workflow. So let's pop into the PACU workflow. Once you're in PACU, you will enter the room in time where the patient is. In this case, they're in phase 1. You will tap what we call the Me button. When you tap the Me button, the logged in user's credentials are automatically entered into the field. If you are not the patient receiving this staff, you can search for someone else's name by quite simply tapping in a few letters and you'll come up with their name. In this case, we're going to go ahead and let me be the receiving staff and how the patient got to me, which in this case is via a stretcher. So the first block we're going to come upon is the post-anesthesia airway, because that is the first thing you're going to check on for the patient. You can use this button to put in the room in time so you don't have to remember it the whole time. How many liters of oxygen the patient is on, how that oxygen is being delivered to the patient, their breath sounds, their respiratory effort, can then cough and deep breathe for you. And if you are using it, it's been incentive spirometer. If you come back in 5 minutes and you need to put this row in again, you can quite simply clone that row. You can tap it and tap the clone button above, and it will allow you to use your new time, and it will have the same data selected. However, if you choose to change up one or two fields, you can save it and you'll get a second row similar. The cloning feature is very cool if you're going to have that patient in there for a while, so you don't have to continuously enter all of the information for that flyout. The next block you're going to see is the pre-op vital signs. You're able to put in a read-only view of the pre-op vital signs to help you ascertain if the patient is doing well in recovery and compared to what their pre-op vitals were. The next block you're going to see is vital signs. You may be able to have an HL7 interface with your monitor where these vital signs will pull in automatically. However, if you do not, complete the flyout. So we're going to, again, use the room in time. We're going to put in the patient's vital sign, their heart rate, their respiratory rate, their O2 sat, their O2 liters per minute, their end-tidal CO2, if you have one available to you, their temperature in PACU. It's important to know that the first temperature taken in PACU is used for the normothermia report in the practice management system. The next block you're going to see is the pain assessment. Now, when I say the next block you're going to see, please know that your center gets to put these blocks in the order that best suits you and your flow of documentation. You will use blocks or not use blocks depending on the need for clinical documentation in your area. For example, the extremity check may not be important at all for a cataract case, but for an orthopedic case, you probably want it in there. Pain assessment is going to show you what that patient's pain level was in pre-op, and then you can assess it. So perhaps they're resting and you don't want to wake them to ask them about their pain. You can certainly just do that, and it will say asleep. Extremity check. We're going to have a little bit of ice. We're going to be elevated. And in this case, it was a left knee that was operated on. So it's going to be the lower left. It's going to be probably pink. It's probably going to be cool because they have a tourniquet on it and a lot of fluid in and out of that knee. You're going to check that capillary refill, and you're going to check pulses if you can. The sensation, probably still tingly. They were probably numbed up a little bit, and they had limited movement. You're going to put the swelling in, and you can put in their strength if you choose to. These are not required fields, but you may choose to complete any of those. We're going to save and exit. Modified Aldrete score. We have built in a unique feature. In the modified Aldrete, you'll be able to put in the current time, but you'll be able to use the latest values that were in the blocks that you've already completed in this workflow. And it will autocomplete most of your modified Aldrete. For example, able to move to extremities, that came from your extremity check. Able to take deep breaths, that was your airway block. This blood pressure was evaluated against the pre-op blood pressure. And you do not have to have the pre-op vital signs read only in the workflow for this system to do that for you. You will have to decide the patient's consciousness on your own. And the O2 sat came again with the vital signs and the airway block. They gave a total score, which you will save and exit. You can, as you complete the above blocks each time, you can use those values repeatedly, or you can just, as we spoke of before, clone the modified already and change just the options you want. Patient safety measures is an optional block. Patient education, again, an optional block should you choose to use it. How orders work in the HST chart is that the orders are designed by a set. The physician signs them. Once they are signed, you'll see a lock there. As you can see, this order was canceled. However, you might say, I really do need an order to admit them. So we're going to go ahead and clone that order. And we're going to say it verbal. And I received it right now from my anesthesia provider. That is how you create a verbal order. That verbal order will appear, and it will appear yellow. It will also appear in the anesthesia workflow, which will tell your anesthesia provider they need to sign that order for you. To sign all of the PACU orders at once, you simply select all and apply your John Hancock. The orders may also have hidden orders. If you have secondary and tertiary pain and nausea protocols, they can be built behind and can be added after the fact. Your anesthesia provider can then come and discharge the order, sign the discharge order, or sign the medication order as you see fit. I'm going to go ahead and hide the unsigned orders. Physician orders work exactly the same way. In this case, the physician doesn't have any orders, but they might have a hint order for a PACU or Tylenol. Obviously, you're going to ask your anesthesia provider for the pain meds, but that is available for you as well. As soon as an order is signed, it comes down to the medication administration block. You can administer it by tapping the administer selected. You can also confirm medication. If it is a medication that your center has decided is a high risk or a high alert medication, you can get another clinician to confirm your dose and your order. And that is as simple as tapping confirm. Have that other user enter in their user ID and password, and they will sign off on it. I'm going to go ahead and have the anesthesia provider sign off on my order for me. Now you can see the slide, the confirmed. Again, you would use this at your center for those medications that are high risk. Obviously, ondansetron is probably not the high risk medication that we would be worried about. In the background, HST always runs a drug allergy check. Anytime the patient has any allergies, it will be noted anywhere you can order a medication or administer a medication. That information will be up here. The med check will either be a green check mark, as we have, a yellow triangle, which is a caution, which often occurs when the medication given will cause sleepiness or central nervous system depression. And the other option is a red exclamation. That is when you have a true allergy or a true drug interaction. In that case, you will have to override to administer it, or you can notify your provider to give you a different option of medication. Drain packing assessment, also an option for block stressing assessment as well. Intake output, what is great about the intake output block is any intake or output that occurred in the operating room and documented by the anesthesia provider will automatically document your intake and output. So you no longer have to chase down an anesthesia provider to complete your intake and output. You'll notice there's a little red minus in every single one of these blocks. The red minus will tell you at all times what needs to be added to complete this record. So I'm going to go ahead and add the intake. I'm going to say it's my intravenous. You'll see it automatically selected normal saline. That is because normal saline is what was hung when the pre-op nurse put in the IV. So it'll select that for you. If anesthesia changed it in the OR to lactated ringers, it will then pre-select lactated ringers. And then you can just put in how much of that volume per fluid went in and save and exit. And as soon as you put in one completed row, you'll get your green check. That doesn't mean that you cannot continue to add urine output or even more fluid before you discontinue the IV. It will total the intake for you. It will also total the output for you. This block is called sketch pad. You can see the little blue X here. That is where the pre-op nurse started the IV. So that is where you can check to make sure you remove that IV properly. However, if they had several unsuccessful attempts and maybe marked them in red somewhere else on this figure, you would be sure to check those as well to make sure that they are still dressed appropriately and not having any untoward reaction. IV discontinued, obviously the time, who discontinued it. It was intact without issue and a pressure dressing was applied. You will have a discharge plan. You will say whether or not you gave the patient supplies, whether or not a prescription was given on discharge or it was called in by you all. Medication reconciliation is a block that is completed by the physician, and you can see that he signed it here. You will then be able to print, when you send this patient home, a print set of medication reconciliation and discharge instruction, which I believe the next block. You get to create your own discharge instructions and your set of discharge instructions. They will flow below. This is editable on the fly. You can add in here at any time any edits that you see fit. This was reviewed already by me in the pre-op area. If you want to review these again with the patient, you certainly can. And the patient signed that they received a copy in the pre-op area. If you do not give instructions in the pre-op area, then this page, this block, will be only in your PACU area. If the patient goes from phase 1 over to phase 2, you will have a separate workflow for post-op recovery phase 2. This patient is being discharged directly from here. But if you did have a phase 2, you would have only in there the information in that workflow that you need to document prior to the patient's release. We also have the ability to keep the patient for 23 hours, which would be an extended stay workflow, which can be built when you build the chart for those patients who may require an extended stay. Patient status is a block where the statuses are designed by the surgery center. So your status here might be ready for family. Once you complete that status, it will appear on the patient locator, both in the lobby and for any other clinician that may want to know the status of this patient. Your discharge status, home to self-care, is automatically populated. If the patient is transferred out, you would select any of the other options that CMS has given us. That is not a list designed by the surgery center. It is a list designed by CMS. Discharge time, discharge nurse, how the patient was wheeled to the car, and who they went in care of. All right. As you can see, the staff block completed automatically. The reason it does that is because it takes the receiving nurse and the receiving time, and then it takes the discharge time. It will put that in for you. If you need to edit that times, the edit pencil is always available. If you need to, let's say I went home and another nurse relieved me, the other nurse is able to put her information directly in here. You can have quality metrics. As many of you know, in January, the quality metrics were reintroduced by CMS. The patient, did they have a fall? Did they have a burn? Did they have a wrong patient, wrong procedure, side to side? You can answer here. If the answer is yes, these become available and you can say which one it was. If the answer is no, the G codes will populate at the bottom. It will include that the patient was not transferred to a hospital. That is because you filled that out in the discharge status. If the patient was transferred, the codes would be different. These tie into a report in practice management so that they can submit that data to CMS. Supplies used can be put in any workflow. Tracking supplies used by workflow allows you to have much better handle of case costing. And any medication you give will populate. You can also populate here. Maybe we're giving this patient an immobilizer. The information on supplies used comes from the preference cards. So this encourages you to keep your preference cards up to date, and it will help you with your charting. Once you confirm the supplies, they flow immediately over to practice management, where they will decrement inventory so that you can make sure that your center always has the supplies that it needs to get the job done. Up at the top, you can see that is where you would print your discharge set. That is also where you can pin a chart if you're taking care of several PACU patients at the same time. You're able to pin that chart and toggle easily between those patients at the bottom. My completion indicator is at 76%. It's going to tell you which blocks were not completed in a timely fashion. So you can simply go back and you can complete that block. Very simple. You can give the patient education. Now you can see 84. That information helps you navigate very quickly to the area of the chart. But if you did not complete the record and the patient went home, don't lose any sleep, because every single night we'll go through your PACU workflow. It actually goes through the entire chart and it pulls out any required fields that have not been completed, and it will generate a task. A task will appear back on that schedule screen in the task manager. Before I go to the task manager, you'll know that this patient turned gray. This is the patient that I discharged. The colors on the schedule change automatically based on the patient's movement. So you'll be able to tell at a glance how many patients are still in the building, how many patients are still in the OR, how many patients are still in pre-op, etc. The colors are your options to pick. I just happened to pick. Task Manager, once you open it, will display for you all of the tasks that you have left to do. In this case, I'm going to tap on this first task. It's going to take me to the pre-op window for a case that I demonstrated yesterday. It's going to say I'm 95% complete. You see, it brought me to the exact block that I needed to finish. And it wants me to sign off on all of the orders, which I have just done. And now you see I got my 100%. When I go back to the previous screen, that patient has dropped off my chart, my list. So you can work through your list. If you have no task to complete, you will get the trophy, which is awesome. Everybody likes to get a trophy. So this was a review of the PACU workflow for HST chart. I hope that this has helped you. If you have any questions, please reach out to HST.